Coming in hot with new research updates. Could GLP-1 medications become part of breast cancer prevention? A large new Penn Medicine study found that women prescribed GLP-1 medications had about a 30% lower odds of being diagnosed with breast cancer than comparable women who were not prescribed these drugs. The study was published in a medical journal by the American Society of Clinical Oncology. Today, we're going to break down what we know, what we don't know yet, and what this could mean for women's health. Welcome to Hump Day Hormones. I am Dr. Jill Jennings, a board-certified OBGYN and Menopause Society certified practitioner.
And I'm Courtney Spann, a nurse practitioner. We work at the Women's Clinic in Little Rock, Arkansas, on the campus of Baptist Health. We are here to talk about all things female hormone related, from puberty to menopause and everything in between. We are here to inform you from a medical point of view about the latest scientific evidence in the world of hormones.
You can find us on social media, Facebook and Instagram, as well as YouTube as Hump Day Hormones. And you can email us your questions or topics for the show at humpdayhormones@gmail.com. We just wanted to have a quick little disclaimer that everything we talk about here is for informational and supportive purposes only, and this is not medical advice, as we are not your provider. Your body is unique, and so be sure to chat with your healthcare provider before making any changes to your healthcare routine. Hello, welcome back to the podcast. We are coming in hot. I feel like that was a good
What day is it?
intro. We played hooky last week because it's summer and it was the 4th of July and it was Courtney's birthday.
Yeah.
And we just all needed a minute. So we've celebrated America and Courtney.
That's right.
Yes.
We're back at it. And I was so excited to see this article come out. You know, we're trying to stay up, and all the new research coming out and all that kind of stuff. And there's always new things coming out. And this one this one kind of caught my eye.
Yeah, it was a stop your scroll.
Yeah, like what? Wait,
yeah. Well, and it definitely makes you wait, 30%? What? And we'll kind of talk about those numbers, and that in the same way that we've talked about the Women's Health Initiative study and how you can finagle numbers to make it seem like this giant percentage, when really, when you look at raw numbers, it's not that many people, but it is a decreased risk for sure. But that 30% comes as an odds ratio, so it makes it sound really dramatic, which is probably the point, and makes you stop your scroll.
Yes.
But then we'll talk about this too. It does make sense. It's like one of those things that, some things you read and you're like, that doesn't even make any sense. But this is that makes so much sense, because we know that obesity is linked to multiple different cancers. And so the inflammation that it causes and all that kind of stuff. So it really does make sense too. So I love it when something kind of confirms what you really already sort of thought. But yeah, just in full disclosure, this was not a randomized control trial. This is not, oh my gosh, go get on a GLP-1 because it prevents breast cancer. This is not that kind of thing, but it is so interesting. And since we had just done a podcast on GLP-1s, we wanted to break down this study.
Yeah. And once you think about it, it makes sense if you're decreasing obesity for sure, but inflammatory markers and all that. It's okay, let's add it to the list of indications, add it to our toolkit of all the things.
That's right. We're getting quite the giant toolkit going over here, but that's okay. And it's not going to be the same for every single person. So,
right.
So they presented this at this clinical oncology meeting. When this new research comes out, if you're really good, really cool new research, you get to present at your annual society meeting. So that's where this was presented. And then they also presented other studies at the same meeting that found that people who already had been diagnosed with obesity-related cancers, which we'll talk about in a minute, there's 13 of them, but obesity related cancers, people who already had the diagnosis and were taking a GLP-1 had a 38 to 50% lower risk of developing metastatic disease. So not only does it help potentially with the prevention, which is the study we're talking about today, but also like in people who already have the cancer. So anyways, it's exciting, but we want to kind of break down all those numbers and then what this might mean specifically for women who are taking hormone replacement therapy or those with a family history of breast cancer. So
that's right. Okay, so let's reminder, what is a GLP-1? If you don't know yet, where you been, but
where have you been?
There's basically, 2 available right now to prescribe under the names of like semaglutide category, tirzepatide category. Semaglutide are going to be the like Ozempic, Wegovy brands. Tirzepatide category is the Mounjaro and Zepbound. And now the oral form of tirzepatide is Foundayo.
Do you like how I just wrote on the script F?
I knew what you meant.
The one that starts with an F.
Oh, no. Yeah.
I always want to call it Fandango, which is, I think, that website you go on to book your movie ticket.
Oh, that's right. That's right. Yep. Yeah. I don't know where they get these names, but
Foundayo, not Fandango.
Yeah. And then there is also GLP-3 retatrutide. That is not commercially available yet. I'm sure it will be. But right now, these studies were based on GLP-1s that are available to prescribe.
That's right.
So they were either getting like Ozempic or Mounjaro or something.
I don't think that the Fandango or Foundayo wasn't
in there. Yeah. It is a new, like, in the last couple of months come out and available.
Kind of like Wegovy was to Ozempic. It's like the oral version for the tirzepatide, the Zepbound type stuff.
Yes.
So,
yep.
Okay, so just what did these researchers study? I always like to look at numbers of people in a study, because if you look at a study and you're like, we studied 25 people, it's like, okay. Right. Maybe we need a bigger sample. But the researchers reviewed electronic health charts of over 110,000 women. So it was 111,646 women. And they were looking in Pennsylvania Medicine System health records. The participants were between 45 and 80 years old. They had a BMI greater than 25, which is like almost every single person. They had undergone breast imaging, so therefore we know they weren't actively having a breast cancer, and they had documented outcomes between January 2022 and June 2025. So not a super long study, but a ton of patients. And so of those, 110,000 people, approximately 15,000 had documented a GLP-1 prescription, while about 96,000 did not. So then if you take those people, this is probably way too deep for some people, but basically they did 2 analyses. So they did the complete population of everyone who was given a GLP-1, which, like we just said, was 15,000 people in this study. And they showed that GLP-1 exposure was associated with a 35% lower odds risk of breast cancer. So, that's
like a new diagnosis of breast cancer in that 3-year window.
In that, January 22 to June 2025, 35% less odds risk of getting breast cancer. And then they did a matched group of about 30,000 women, and they matched those 15,000 that I'm talking about that got a GLP-1, and they matched about 15,000 that were not on a GLP-1. So they tried to match them. Let's go try to find, between this 45 and 80-year-old, let's go find the 50-year-old that is they're the same age, the same race or ethnicity, the same BMI, the same breast density, and the same diabetic status. So they're trying to make them equal, kind of like what you would hopefully get a better with a randomized, they're trying to make it a little more matched like that. So in the matched analysis, GLP-1 use was associated with a 30% lower odds risk of breast cancer. So the same thing just about held true.
Yeah.
Total population 35, matched analysis 30%. So, and then, we are talking about an odds ratio, which probably gets way too deep into statistics, but an odds ratio is not the same thing as an absolute number. So this is like what happened with the Women's Health Initiative when we said we were dealing with 30 out of 10,000 versus 38 out of 10,000. And you say, oh, that's 8 out of 30. That's about 20%. Oh, 20% more risk of breast cancer.
Right.
Like that's how that happened, and we were very critical of that. So this is how this number happened too. So I feel like it's fair to be kind of equally critical of that. But if you do an absolute difference, and I mean, I'm not going to bore you with walking through the math of how you get to this, but just if you do the math and you do the absolute difference, it turns out to be about 1 fewer breast cancer per 100 women. So, not a massive thing. So it's 30% makes it sound like it's 30 less women out of 100.
Right.
And it's really not if you put absolute numbers on it. And so that's what makes statistics pretty tricky. But just in full disclosure, it is a decreased risk, but it's probably not as like stop your scroll as we initially thought. Yeah. And then, I always look at studies, or I guess we're taught to in medical school and residency. We always had this thing called Journal Club where we met, I think it was once a month or maybe twice, I can't remember. And we would have to go over journals, and it teaches you how to read through medical research and kind of be critical of it, look for things like odds ratios, absolute risk, all this kind of stuff, and then what type of trial it was and all that. So I always read studies sort of critically like that, which is, I think, what we're taught to do. But this was not, in full disclosure, a randomized trial. So women were not randomly assigned to receive a GLP-1. And this was like a retrospective, like researchers were just looking back at like what was already, on the record. So that means that there may have been a difference in the women who did not and who did receive the GLP-1, like from their baseline. There may have been a difference in those women. And I think that's why they tried to do that matched analysis. But if there's a difference in those women, then that's not going to be fully captured in this study. Even though I do appreciate that they tried to match it for the things that they could, but there's lots of other
factors that go into it
besides just our age, our race, our BMI, our breast density, and our diabetic status. There's other things that are not going to be fully captured even after the matching. So,
well, and this would be a hard study to do with like a randomized control trial, because
you're going to know if you get the GLP-1.
Yeah. And like, you don't know if you're going to end up being the one that like gets a breast cancer, so it's like, I don't, you know what I mean?
I know. I was thinking about that
would
too.
be really hard.
Or like, how do you randomize it? Like, you might or might not get the GLP-1. Like, no, you're going to know because you're going to start losing weight.
Yeah. Be symptomatic probably of
you
would know if you got it,
which goes back, I mean, I equate everything to the Women's Health Women's Health Initiative, but like that's why they had to have such older patients, because if they couldn't randomize you to estrogen or not estrogen. Like, you couldn't have hot flashes, because if you got the estrogen, you'd know if they
would know.
Yeah.
And the whole point is like, the patient's not supposed to know, the researchers are not supposed to know, nobody's supposed to know. So, and these studies are just tricky. So I feel like looking back at it is kind of the only way to, I don't know, to accurately do this.
I know, but yeah, association does not always mean causation.
Right.
So we did not prove with this study, like, it's not an accurate statement to be like, okay, well, GLP-1s prevent cancer. That would not be an accurate statement. So I always, like, when you first say that, like, association doesn't mean causation, it's like, Well, yeah, I mean, yeah, it does kind of, right? If they always happen at the same time. But then one of the like classic examples, which I remember Rousier talking about it in that course that we went to, is the statistical association between the number of ice cream cones sold and the number of sunburns in a month. And so, that would be like you trying to say ice cream causes a sunburn, because everybody that eats ice cream, you're more likely to get a sunburn. And it's like, no, you're probably just more likely to eat ice cream when it's hot outside.
Right. And then you're getting a sunburn when it's hot outside too.
Yeah. So it's one of those, association is not causation. So and the variable there that you would have to capture is the hot summer weather. So there may be some variable here that we're not catching, but that's what's so exciting about this study is because the biology does make so much sense. And we think we kind of know what those factors we're not capturing are.
And I think that's kind of the same thing that we talked about with PCOS, PMOS. They made the name change because it's starting to become known that, like, okay, insulin, inflammation, all of those things are big key drivers in these disease processes. And I think we're starting to like crack that a little bit too with like oncology world, so I think it's just kind of like opening the eyes of all the people.
That's right. And this is one of those like, did you know facts? You start reading about this and I'm like, yeah, we do know a link between obesity and cancer, but let me just put like an exact number on that. And, if it forces, that's what I love about writing these podcasts, forces me to dig in. But per this is off of the CDC. So per the CDC data, being overweight or having obesity is associated with the higher risk of getting 13 different types of cancer. And those 13 types make up 40% of all of the cancers diagnosed in the United States each year. So, I mean, that's pretty crazy.
I feel like an indication for a GLP-1 should be like the prevention of these 13 cancers.
Right. Like, or maybe it's not like the reason you give it, but like sure can help. And I mean, I think that we have to care in women's health because if you look at the list, the ovaries are on there, the uterus is on there, the breasts are on there.
Yep.
Like in my world, the only thing that's not on there is the cervix. And so it's like, I mean, I'll just read the list. Adenocarcinoma of the esophagus, postmenopausal breast cancer, colon and rectum, uterus, gallbladder, upper stomach, kidneys, liver, ovaries, pancreas, thyroid, meningioma, and multiple myeloma. Like, crazy.
I mean, like 5 of those are like full up our world.
Yeah. And then, I think you do kind of take a step back and you're like, well, why? Why does being overweight or obese, like why is obesity associated with an increased risk of just cancer in general or breast cancer? Like why does that happen? And I mean, there's probably a little bit of, we don't know. I mean, that's always with science. We're still figuring stuff out. But I think we have also starting to like crack the code that like fat is not just like a place that we store our extra calories, that it does things in our body as well. I think everybody's kind of waking up to that fact.
Becoming aware that it's like there are certain types of fat that are like metabolically active.
Yes.
In a negative way. And like release inflammatory kind of things, like inflammatory chemicals that kind of causes this low grade inflammation, which over time, leads to like chronic diseases.
Yeah. I mean, the best explanation that I could come across in trying to like wrap my own mind around this was that when fat cells are overstretched, that they start to release these inflammatory chemicals. And so those are called adipokines and cytokines. And then adipokines and cytokines can block insulin signals. So the insulin that you have can't do its job as well when all of this stuff is being released like it shouldn't be out of your fat cell. And then if your insulin can't do its job like it should, then your insulin's going to go up and you're going to become insulin resistant.
Mm-hmm.
And so, I think that again, you're going to get yourself in a loop of like where you can't even help it anymore. Your fat cells are releasing the things and you're becoming insulin resistant. And like those two things are like feeding off of each other.
Yes. Yeah.
Yeah. And we don't have like okay, I'm going to prescribe this big pharma medicine to you that's going to make your adipokines go down. I mean, we don't really have that drug like as one marketable drug that you go pick up at your pharmacy. I mean, there are lots of things you can do to decrease inflammation, but we do have the drugs to decrease your insulin level. And, that's why we're talking about GLP-1s.
Right. Yeah.
So,
and decrease fat and visceral fat and all of that.
And then I think with breast cancer specifically, this gets really confusing to people, but excess body fat produces estrogen continuously through the aromatization of androgens. So like our androgens, DHEA and testosterone, mostly they can get sort of like changed chemically by enzymes, and fat cells are one of the places that this enzyme is like in a high abundance. And so you can change your DHEA or your testosterone to estrogen. But it's usually not estrogen like we talk about estrogen or like we're prescribing estrogen. It's estrone, which is typically like a much weaker type of estrogen than estradiol, like we make in the premenopausal world when we're ovulating and like we prescribe. But estrone can bind different receptors with different affinity. And it also, like if you have this low kind of constant level of it, then that may become much more of a problem like after menopause. Because you used to have estradiol, and estradiol is going to basically like knock estrone out of the way and bind the estrogen receptor because it has so much a higher affinity. But after menopause, you don't have any estradiol anymore unless you're taking some. You don't have any estradiol anymore. And so all your cells can see is estrone. And they think it is possible that the way estrone binds a receptor and behaves in the cell is so much different than estradiol. So
so that like estrone specifically can like accumulate in the background, cause overgrowth if cells are already damaged by inflammation and DNA damage over time, which I mean, that happens as you age, I don't know that there's like a lot that you can do about it.
Adipokines are already
like very rarely are you going into menopause just primed up, ready. Like more times than not, there's already like some chronic disease probably going on in the background. And then this estrogen can make it worse also. And I feel like we've talked about this before, but it's like, why all of a sudden during menopause, the estrogen, and so much like your body's like way of trying to find estrogen makes you store that visceral fat because from that visceral fat, you're gonna like produce some estrogen, which is actually going to be estrone.
Right.
So I always think that that's super interesting too. It's like your body was trying to help you out,
Didn't quite nail it.
But it was the wrong one.
Yeah, didn't quite get it right there. But so, I mean, I guess what I'm leery of is that someone's going to hear like, well,
estrogen.
I thought you told me estrogen caused breast cancer, and now you're telling me that estrone might be a bad deal. And it's like, that's not estradiol, and it doesn't act like estradiol.
That's right.
On the cell. But so this does not mean that the estradiol that we prescribe after menopause causes breast cancer. So the opposite, actually, the exact opposite, has been shown in multiple randomized controlled trials. So what we're saying is the best trial that you could do, we've done that multiple times with estradiol and never really shown an increased risk of breast cancer. In fact, most of the studies show decreased risk, especially if you're using only estradiol and not a progestin. So the progestins were the problem. But yeah, kind of obesity, inflammation, that all creates this unhealthy hormonal environment that is causing the DNA damage and causing your cells to behave differently. And so, you know, that's going to all be just sort of random, haphazard happening. Hormone therapy is carefully dosed and monitored to restore like what level you need of the estradiol. So trying to be more natural to what we produced before we were in menopause. And that, like I said, that estradiol is going to bind with much more affinity and has much more beneficial activity within a cell than this estrone, which is not always great. So anyways, I hope that makes sense to everybody. It's progestins, not progesterone, and it's estrone, not estradiol.
That are the problem children.
Yeah.
Yes.
They're the problem.
Yes.
And so then, okay, it's like, okay, if we're on board that obesity and inflammation and stretched out fat cells and adipokines and cytokines and estrone are all not fantastic, then you start to understand like why might GLP-1s medication like help lower a breast cancer risk. And so there's lots of explanations that could help that make sense. I think the most obvious is that you lose weight, you lose the fat cells, you lose kind of the ability for them to be pumping out all this extra adipokine, cytokine, interfering with your insulin resistance. So I think that's,
and if it's doing that, then you're gonna, you know, lower that insulin signaling and make your insulin more receptive, and it's just going to work better. You're not going to have to keep on pumping out more insulin to kind of get the job done.
I know. And also, did you know, I did not until I was writing this podcast, that insulin, also high insulin. So if you get in this like insulin resistant state, high insulin increases insulin like growth factor. It's like, well, obviously it's insulin, so it's going to increase insulin like growth factor. But I never thought about it like that. But insulin like growth factor is a hormone that promotes cellular growth and reduces programmed cell death. So that gets into kind of a longer story of oncology kind of things, but our cells aren't made to live forever. We're supposed to be rapidly turning over cells. I mean, you know, everybody knows that with like our hair and our skin, but that happens with all the cells in our body. But like we want to be able to destroy cells when their DNA is damaged and they're not good.
Right.
And when we lose the ability to do that, these damaged cells proliferate longer. But this insulin-like growth factor is making them grow and reducing their ability to like basically kill themselves off when they're damaged. And so that right there is like, seems like a direct cancer link in itself.
Yep. Just having higher insulin levels, which is just being insulin resistant. That's wild. I didn't know that.
I've just never really paid attention to insulin-like growth factor. I've never really given that a second thought. I feel like people kind of throw that term around a lot. And we talk about that with babies and like babies of diabetic moms. So when you're diabetic and you're pregnant, it's an insulin resistant state. And so that insulin is going to cross the placenta and it acts like a growth factor and creates these big babies. So we all know that like diabetics have these like, 10, 11, 12 pound babies. But that's really why is like that insulin is promoting the growth. And again, it's one of those things like I've been knowing that for 15 years, but I've just never put it together like really with the cancer world.
Yeah, that's wild.
I know. And then another mechanism would be reduced inflammation. So chronic inflammation is what's causing the DNA damage and interfering with like normal cellular repair. And so increased inflammation is going to create an environment where abnormal cells are more likely to survive. And so if we reduce our adipokine, cytokine load, then we're going to reduce that. So
yeah. And then another one is possible direct cellular effects, which is kind of the same with like the insulin-like growth factor. But lab studies have suggested that GLP-1 signaling may affect cellular proliferation and apoptosis, which that's where they like die off.
Right.
And then other like tumor-related pathways. So, I mean, that's pretty cool that like there's already studies showing that.
Yeah. It's just, I don't know. It's pretty wild. But anytime you see why, like, they can't just come on the news and like explain a study like this, right? They just have to say, well, we have this study that showed GLP-1s reduce your risk of breast cancer. And they really can't elaborate, because what are they going to do? Like, have me on the news for an hour telling you why? You know,
Right.
I mean, I will if they need me to do that. But in general, there's just not enough time to like explain it all to everyone and in a way that it makes sense.
Yeah.
And so, you know, we're left with just these popped up headlines. But yeah, the headlines do need qualification in that this was not a randomized control trial. The duration was not very long. And so a lot of people may say, well, doesn't it take longer to develop a cancer than, you know, 2.5 years?
Right.
And so the duration wasn't really long enough. The dose, I don't really think they qualified. Like, were these people on a 2.5 or a 10 or 15? I mean, so dose wasn't really brought into the picture. And then breast cancer subtype, like, were they estrogen receptor positive, HER2, triple negative? That wasn't discussed. Were they postmenopausal or premenopausal? They didn't really.
They was between 45 and 80. So it's like it could have been
They were at least perimenopausal.
all the things.
Yeah. But yeah, I think that it also, there is a problem in that there was a study from 2024 that looked at a cohort of type 2 diabetics, and they showed a significant reduction in 10 out of the 13 obesity related cancers. I'm going to spare you from like listing them all, but breast was not on there. So this like conflicts directly
Right.
with the 2024 study. So, but I mean, that study did show reduction in 10 out of 13 cancers. And so I think what this really means in the end is like nobody is prescribing a GLP-1 for breast cancer prevention. Kind of like we don't prescribe estradiol because it's going to make your skin and your hair prettier. Like, it probably will, but that's not like an FDA approved, you know, indication for that. I mean, brain fog is not an FDA approved indication, but I mean, we use medications like this all the time, but like Courtney was saying earlier, it's in the toolkit. And I think it's really useful, especially because we test for like inflammation and cortisol dysregulation and adrenal overdrive and all this kind of stuff that is all wrapped up in insulin resistance. We test for insulin resistance. And so I think if you've got somebody that is obese, they have insulin resistance, they have other markers of high inflammation, whether that's their cortisol, their C-reactive protein. I mean, you can test IL-6, all that. I mean, I'm not saying that you need to come get all those labs to know that, but if you've got somebody that's like kind of this, I mean, honestly, the PCOS patient,
this inflamed insulin resistant girl,
then maybe it would be, and she's like, oh, and I've got this big family history of breast cancer, then you're like, well, maybe a GLP-1 would be better for you than metformin. But probably anything that is going to reduce your insulin resistance. So, you know, nobody's also done a head-to-head trial. But yeah, probably if you keto diet and starved yourself, you would become less insulin resistant. And probably have some benefit that way too. But this just may be like a healthier, you know, easier way and much more like, you know, likely to work. A lot of that, like, I'm just going to do it with diet exercise. It's hard to break that cyclic, like insulin resistant cortisol stuff without, you know, something to help. And so maybe it would be good for those people that are already a setup for that.
That's right.
Yeah. I mean, I don't think that it's like, oh, GLP-1s for everybody. I mean, it's starting to seem that way.
For a lot of people, though, I know it's like all the indications of like sleep apnea, BMI's, you know, greater than 27, and you got some high blood pressure. I mean, it's wild. I'm super excited to see like where the studies are going to go with all this. But there's just still like a lot that we don't know. And so I think like the exciting part is that treating obesity and metabolic dysfunction, there's a lot more to that than just like weight loss. You know, there's some big like underlying major effects that you're doing deep down. And this is potentially one of them, decreasing that inflammation and insulin, which could potentially kind of be a negative setup for some cancer development.
Yeah. And so I think that in general, anybody who's in the know, we've moved far past like you just need to diet and exercise. Bye-bye. I mean, we've moved far past that and kind of like we need to know like everybody, like that's what I tell my patients all the time. Like everybody should be diet and exercising. That should just be like our baseline. We're eating healthy and we're exercising.
Yeah.
That should just be existing. But like if you are insulin resistant, I think it's our duty to figure out who those people are, and it's freaking easy to figure out.
Yeah.
And then offer them some different treatment besides diet and exercise, especially if they come in and say that they're already doing that, which is like 95% of my patients.
Yeah. I don't know anybody that's like, I'm not doing nothing. You know, I'm just sitting on the couch.
I'm eating bonbons.
Literally. Like everybody's trying something.
Yeah.
You know, and it's like, yeah, don't tell them just to like go out and start walking 4 miles a day and eat a healthier diet. Well, they probably feel like total crap and cannot do that because their hormones are crazy and their insulin's so high. It's like you really got to come in and start adjusting, you know, that, and to at least get them kind of motivated and feeling better to start making healthier choices.
Yeah. I mean, yeah, I think obviously we know a lot more now, but I still see patients all the time that have been, you know, told for years, and they're in tears telling us because they're like, I swear I'm trying. Like, I swear I'm, you know, going to the gym 4 times a week. And I'm like in my head going, you're going more than I am.
Yeah. And their insulin's like 40 and you're like, yeah, you're not going to like out diet, out exercise that.
I know.
You know?
I know.
But nobody's ever checked an insulin before.
Yeah, but they're like, but my A1C is fine. Well, no, but you can still be insulin resistant like long before your A1C is a problem. So we've got a whole podcast on cortisol, on insulin resistance, on all the things. So this is number 78. So scroll back to the other 77.
And we are getting old.
We're getting old.
Yeah.
We do talk about, I feel like, the same themes come up in everything we talk about. And it's like, how are we now talking about breast cancer and insulin in the same sentence? You know, but
it all makes sense.
It all makes sense. So we're going to keep kind of watching all this unfold. I mean, I think anybody kind of in the world of metabolic health, which should be everybody, right? It includes heart disease, diabetes, everything. So all the people in the world of metabolic health are going to be, I mean, the GLP-1 story is just getting started. So we have much more to come, but we'll let y'all know.
That's right. Okay, quick reminder, everything we talk about here is for informational and supportive purposes only. It is not medical advice. Your body is unique, so be sure and talk to your healthcare provider before making any changes to your health routine.
Yay. I have no idea what we're talking about next week.
I did just see, okay, we love Mary Claire Haver, and we have done, I mean, very similar episodes to this, but this was a new study that came out like, I don't know, maybe last month, but it's talking specifically about like target estradiol levels for optimal bone health.
Love it. Love it. And that's why we're obsessed with checking your levels.
Yeah.
And why we are glad your hot flashes are gone, but that's not the end of the story. So yeah, maybe we can talk about that. Honestly, I'm just trying to survive the summer. I'm going to need these kids to go back to school. Go back to school.
It's coming. I mean, we only have like 4 weeks of summer left. But yeah.
My sweet little George has swimmer's ear. So now they said we can't even swim for the next couple days. And I'm like, what would you like me to do with my child?
Right.
So we're surviving over here, but we will find something and we will talk to y'all all about it next week. And y'all have a great hump day.